this matter of really changing everything to digital was like breaking the sound barrier, you know. Till there it's always stressing, and suddenly everything's quiet.
Hello everyone, and a very warm welcome to the latest edition of our webinar series. It's called Innovation Spotlight, Digital Pathology. My name is Corinna Tuna, and I'm very pleased to host today's session on behalf of Smart Media. For those who may not yet know us, Smart Media is a provider of digital pathology solutions, including a diagnostic platform with an open image management system. And all our solutions are designed to support and connect scalable digital workflows. We see every day that successful digital pathology is never defined by one component alone. It's not only the scanner and it's not only the image management system. It depends on how all the individual elements of the workflow work together. And that is exactly why today's topic, the monitors, matters to us. Once a case is reviewed on a screen, the display becomes the final visual interface between the digital images on the one side and the pathologist making the diagnosis on the other side. And this raises several important questions regarding the optimal selection of the monitor. And I'm very pleased to welcome today's expert guest, Danny Dero, Director of Product Management Innovation at Barco Healthcare. And yes, Danny, before we move into the topic, could you please introduce yourself?
Yes, thank you, Corinna. And thank you for reaching out on this topic. I'm Danny. I work very long for Barco, have a background as a software engineer, then did a lot of development work on calibration and quality assurance of displays in different markets, but did some groundwork on the grayscale standard display function in DICOM committees and IEC committees, also working with the ICC color profiling. Then moved to product management, did that for multiple years, and now I'm part of Barco Labs, which means we're looking to new technologies. And I'm active in everything related to color accuracy in digital pathology towards displays, but also, for example, to quality checks after scanning. We bring new products to the market, to the business unit, and my role is to have an early definition, make business cases, etc.
Okay, then let's dive deeper into the topic. What changes for the pathologist when they move from the microscope-based review to the screen-based review of the slides?
So, very good point, of course, and it's a whole transition to make because pathologists are used to look to a microscope. If you look to the current workflow, it's basically the whole wet lab. You receive the slides. It's a logistic process. And then on the slides, you look to the microscope, you generate a report. If that is then already digital, we assume you probably use speech to text to create that report. But if you move to the digital part, you're adding quite some additional steps. And one of the steps you're adding is, first of all, you need a scanner because you need high resolution images to be scanned. You better do some quality checks after scanning. But then you have these large images coming up, and that means you can allow or you can do much more things with that. So first of the things you can do is you can do a kind of a triage and get urgent cases with some AI pre-processing that you could do. Typically, after that, once you're digital, you would send the case to an assistant where the initial diagnosis can happen. Again, there AI can be used, whatever it is. It's regional based, it's computational based, but then the case can be sent to a second opinion still, because that's the advantage of having a collaborative session with just digital images. Before it is then really signed out finally by the main pathologist, where the diagnosis is final, and then the report is generated where then the slides can be archived or then go into a kind of a digital archive. So a lot of changes from microscope to the monitor. So that means an ergonomic major step forward, because you certainly have access to a nice display where you see all the colors on. You don't have this ergonomic challenge anymore of looking to a microscope the whole day. It enables collaboration and consultation, triage. You can do quality metrics. You have digital turnaround time, but basically also the interpretation is going to be different on a screen compared to the microscope. So they often call it also the adjusting the pixel memory. And it's very important to say there that the display is of major importance. You could say I'm working on my own desk. That's one thing, but you basically want to have consistency with other pathologists on their desk. So they also should have a decent display. If you do remote collaboration with a whole team, you all want to have image consistency over the different workspaces. So the display is of major importance here.
And we are talking about image consistency. What do you think, which display characteristics are especially relevant in digital pathology? Is it the resolution or the color, brightness?
Yes. So everything starts with defining your workspace. I think if you go digital, what we typically see is your setup. Most often we see a 3-display setup. So 3 displays, you have your work list on the left, you have your imaging displays in the center, and you have your reporting office info display on the right-hand side. So if you have those 3 displays, you need some space on your desk. If you want to have an ergonomic, nice user experience, there are studies who state like the best reading distance is about 50 to 70 centimeters, which means that a 27-inch is the optimal size for that. So you need 27-inch, and of course you need a resolution, because those images are being scanned in not only 10x, 20x, sometimes even 40x. So you will have to zoom and pan a lot on these images to see all the details. So the resolution is at minimum where we see there is 4K, that's also 8MP. And that's 27-inch in the center. We do see that some people are also selecting 32-inch. 32-inch is slightly bigger, but then we often see that they stick to a 2-display setup. So you basically have your work list display and you have your imaging display then being 32-inch. Besides that, it's the whole workspace, meaning your performance, your ergonomics, a nice chair, an input device. It is also important. Some of them use an additional keypad where you have shortcuts to generate automatically. For example, you're reading prostate. It brings up the prostate template for your report automatically with one click to a button of a keypad. You will have audio devices because you're using speech to text. You have collaboration software. So it's a whole setup that you have to consider. And the display is the main part of that. So if you go shopping for a display, assume that you go into this nice shop to buy a new TV. It's more or less similar. They all show the same video, but they all look different in luminance and color. So if you look for new customer grade or office displays, they are all over the place and they're never exactly the same if you stick to that. That's why it is important to understand what is the difference between an office display and a medical grade display. Now, looking to the optical stack of a display, you have the backlight, which is generating the light at the back of the display, which is typically an LED backlight. You will have a diffuser in front of it, and then you have the LCD material opening to generating pixels, and then you have the image at the front. So we do not talk about brightness and contrast anymore if you're talking about a medical grade display. We are talking about a calibrated luminance, because you want to have the same experience in color and luminance over the whole lifetime of that display. And how is that achieved? It's achieved by adding sensors. So there are internal sensors looking to that backlight. There is also an option on some of the displays to have a front sensor. That means this front sensor is actually looking to what the pathologist is also looking at, meaning you walk away from your desk, you get back to your desk, the display pops up automatically, and it will immediately maintain the luminance that it was calibrated to. So if this was 400 candela per square meter, for example, that's a high luminance because pathologists, they work in a pretty bright area. But you can assure with a medical grade display that this is kept for the lifetime of the display. And that's all that technology that is in there. It also requires a special kind of backlight to have that spare period to say, I will keep on having enough light to keep on generating that 400 candela per square meter over 3 or 5 years even.
And yeah, many labs already have standard office monitors in Germany it's called MediaMarkt or Saturn. Where can those be sufficient, and where do your medical grade displays provide a clear advantage? Is it only the calibration?
No, very good point. So where we're talking then also about the application, the task. So looking to the primary monitor, the medical grade monitor that a pathologist is using on a daily basis to take decisions, life critical decisions, looking to H&E and IHC slides mainly, or images. That's of course the standard way of working. But there are other use cases or other, besides the physical location, there are other locations where images are looked at. Think about frozen section. This is typically very much time driven. It is often done by a laptop. It's done often through collaboration tools, which is not that obvious. You can look to cell counting. There are applications where you say, we need to count some cells. Color accuracy might also be important there. If you need to do grading, for example, for prostate Gleason score, you don't only have to look to the structure. So you don't only need the resolution, you also need the color accuracy of that display. And fluorescent images are also like that. So you might expect that it can be quite important to have repeatable results when you look to fluorescent images of slides on different patients. So there are a whole set of applications to consider. Now, if we look to an office monitor, and you measure the behavior of an office monitor. It looks nice and bright from the beginning. There is a study that I want to share afterwards, where you can see that the luminance drops after 2 to 3 years with about 25%, because it does not have any sensor technology to stabilize. That's only luminance. And you also see typically for those kind of office displays, they make a shift to a bluish. So after 2 to 3 years, they become much more bluish than the original one. So think about using different displays, office displays, with multiple colleagues of not the same age. You will be starting to look at something which really becomes a moving target. So that's also an issue. Uniformity on the screen is also important. If you put a kind of a neutral grayscale full background on your screen, you might see some spots or in the corners more or less luminance. Medical grade displays have technologies to make that more uniform. There are even displays who can do that per pixel, and then it keeps and it applies correction for getting the luminance stable and also getting the color stable over its lifetime, also towards uniformity. And again, in that case, you're going to need a special backlight to compensate for that, because as it ages, you will have to keep on performing that correction. Another aspect is the color gamut. A color gamut, that is the specific range of colors it can reproduce from the visible color spectrum. So, a display is driven by three signals of red, green, and blue. It's using additive technology to generate all the colors. And if you look to those primaries in the color space, you will have standard sRGB, which is the default also by office monitors. Now we do see a trend that there are more and more flat panels, the panels inside medical grade displays also, that allow you to go broader in that spectrum. And that is called a wide gamut display. DCI-P3 is a new upcoming standard there. And if you have a wider gamut, it also means that the colors will look more vibrant and better. So there you will also gain, if you want to represent H&E slides, IHC slides with specific staining, you will see that those colors will appear much better on a display with a wide color gamut. And another feature which is also quite important for digital pathology, it is the way you work as a pathologist when looking to the imaging screen. We did some investigation also with eye tracking, and you can see that the pathologist is using the full screen. A radiologist will mainly focus at the center of the screen, but as a pathologist, you're zooming in and you're doing a lot of panning of that image, and you want this to be smooth. You don't want any latency when you move these images around, and that's exactly what is then called, you need a display with a high refresh rate. And not only the display, the graphic board also has to support that. If you move images around, you want it to be smooth, just the same and a similar experience if you review a slide, a physical slide under the microscope. So therefore, you need a medical grade display with that high refresh rate being quite important. Again, there are studies where you have seen this being compared, a medical grade display compared to standard consumer of the shelf displays, and you see that the concordance in glass is only 100% matching on the medical grade display. You are losing some of this concordance with standard displays.
You told us that there are different requirements depending on the use cases. So what do you think? What should labs ask themselves before selecting a display for digital pathology?
Good point also. Of course, we start with the most obvious one, which is the routine diagnostics and the remote consultation. This is your diagnostic loop, so it mainly replaces your microscope. You're looking to a device that is medically regulated. That's important. So it basically means that people are asking there through a typical benchmark, we need 4K, 8MP, we need sustained calibrated luminance, pretty high, 300, 400 candela per meter squared. You need a high contrast ratio with uniformity correction, 120 Hertz refresh rate, and you want a kind of an automatic quality assurance because you don't want to run around or do checks with a manual colorimeter or a puck every 3 to 6 months. So making that the choice for a medical grade display does make a lot of sense. That's primary diagnostics. For remote consultation and telepathology, that also makes a lot of sense. For a medical grade display, maybe with a little bit lower specs, where you say, I still want to have 8MP with 300, etc. But also still there, you're reviewing images, which are quite important. Only in a case where you don't do any diagnosis, no reviewing, their standard office displays could be used. Now looking to the other aspect, because there was a question also on tumor boards and or multidisciplinary team meetings, there you typically only justify the decision you have made on your own desk or on your own display. So if you need to go to an MDT room where there's only an office display, it's perfectly fine to highlight and share a part of the imaging to say, this is why I took this decision. There is an exception, however. There might be some MDTs where you have multiple pathologists, again, comparing and looking to images, where it could make sense to also there look for medical grade displays. but the normal use case there is really non-diagnostic. Looking to the area of research and AI development, which is pretty broad. It could be discovery, it could be drug discovery or development, biomarker quantification. So there we see that in a lot of cases, CROs, they really focus on research and they really want to reduce the risk. So they really prefer already to use medical grade displays, especially if they are doing some work and they want to do a clinical validation later on. So they always want to have full control over the chain from scanner to viewer to display. And if you have that all regulated, if it's an FDA cleared device or an IVDR certified clinical display, you don't have any risks because you know that this is okay, that you have the display under control. In new pathology settings, like for example, new grading or companion diagnostics, there also we believe that medical grade displays do make a lot of sense. Machine learning, you could think if you're starting to annotate clinical AI data on WSIs, on images, there again, you're generating ground truth. And if you do that with multiple people, you better have the same experience, you better use the same displays, and medical grade displays are also the best choice there. The only space where you could use standard office monitors might be in an early stage academic discovery for research use only, where there's no intent to ever commercialize to a clinical product. That's for AI and research. If we look to education and classrooms, then I think you start from a teaching pathologist who's the lead. He will have a medical grade displays, just like the resident, but for pure educational purposes, like highlighting a region of interest, that might not be important, that you might do the job there with a decent 4K office display.
Okay, and what do you think, what are the most common misunderstandings around display quality?
Yes, I would like to highlight at least 3 of them. So first of all, a lot of people, they look at displays and they assume that it's good enough. They buy an 8MP monitor, which is good for gaming, for example, because that has a high refresh rate, and it produces a nice sharp image. But a medical grade display is a scientific tool. It's calibrated for linear truth, for diagnostic confidence over time. So these kind of just gaming displays, they are not built for that kind of purpose or usage. The second one is very much related to this, and it's really comparing the initial performance compared to the sustained stability, because you might have a nice display when it looks great in the beginning, to what I just told you over what's happening over time. Luminance goes down, the color is shifting. If you don't have that under control, you are looking to basically a moving target. And then the third one is often what we also see, that people look at their budget. That's obvious, but you look to the things that are most expensive. And that's first of all the scanner, that is an IMS, that is a VNA, and then there's no budget left anymore for the displays. And then they end up with office displays because they have no budget anymore. Although this is, of course, of primary importance, because your eyes as a pathologist are really looking to that display and are making those life-critical decisions.
Okay, and one last question. As mentioned in the beginning, digital pathology depends on many connected components in the workflow. First, there's the scanner, then the image management system, the AI tools, the storage, the network. How does Barco work with all these partners in this ecosystem together?
So we are a B2B company, so we always work with business partners towards co-validation, regulatory alignment. So we work with scanner and IMS vendors. Smart in Media is one of them. We go to conferences, we showcase our displays, they showcase also our displays. We work with case studies and end users. So I can share that we have Dr. Geppert from University Hospital in Erlangen is doing some research for us on cases with a specific barcode display. And we have built the first FDA cleared display that can be used with any system because for FDA clearance. And then we are also active in DICOM Workgroup 26. So where we are pushing to, for example, also validate the wider gamut of the displays and also QC after scanning. Besides that, we have our QA solution with more than 100,000 displays connected in radiology and pathology. Where we do this, we can enable this automatic quality assurance of the displays.
Okay, and if I'm a user or I want to become a user, do you provide demo monitors for your customers and prospects?
Yes, that is something we can set up with our sales people. I think Antje is in the call, who can help here, because I don't know the logistic process of that, but I do know that we support that indeed.
And we have here participants from different countries. I think you work in all European countries, right?
Yes, we're quite international. That is correct.
Okay, so let's come to the questions of the audience.
So on a medical grade display, there are most of the vendors, they provide internal sensors who can do automatic measurements. This is typical. So you can only measure the white with a backlight sensor on the back. But if you want to measure colors, you need a front sensor. And most of these medical grade displays have a front sensor. So that means if you have then some software, you can schedule it to say overnight, I want this display to warm up, do its measurements, and then it's going to send it over. It stores it locally or it sends it to a central server. So if you want to do that with an office monitor, you basically can use similar software, but you will have to do it manually with a colorimeter in front of your display. It's only stored locally. You don't have a lot of tracking of that. So it's quite time consuming.
I think we are just in time now. So Danny, thank you very, very much for this insightful and highly practical conversation. Thank you very much for joining us. Thank you for your time. I think the discussion has shown that display quality in digital pathology is not simply a question of screen size or resolution. There's much more behind it, and we are thankful that we have companies like Barco who provide really medical monitors. Okay, we will start into a short summer break and we will continue our webinars in September. And so have a good holiday season and see you there in September.
Yes, happy holidays. Thank you all. Thanks. Bye-bye.